they are giving afferent arteriole. These are the afferent arterioles. Okay, afferent arterioles are forming the glomerular capillary plexus. From the glomerular capillary plexus, efferent arterioles are formed. Efferent arterioles are forming peritubular capillary plexus, and the nephrons are of different types. Okay? Cortical nephrons, juxtamedullary nephrons. For cortical nephrons, these efferent arterioles are mainly forming the peritubular capillaries. And for the juxtamedullary nephrons, it is forming the vasa recta. So these are the vasa recta, roots of vasa recta. That helps in counter current exchange mechanism along with the loop of the hand. Previous one. आगे slide पर जाओ तो. So interlobar artery branch and continuous arcuate artery along the base of the pyramid. Arcuate arteries give interlobular arteries that traverses the cortex towards the capsule. Interlobular arteries give afferent arterioles. Afferent arterioles give rise to a network of glomerular capillaries that unite to form the efferent arteriole. And efferent arteriole give rise to second set of capillaries called the peritubular capillaries. Efferent arteriole from the juxtamedullary glomeruli form the vasa recta, and that helps in countercurrent exchange system. Okay? And peritubular capillaries in the cortex drain into interlobular vein and later in arcuate vein, enter lower veins and finally into the renal veins. And capsule of the kidney drains into stellate veins, finally into the interlobar veins. Next. See here, near this is the cortex. Capsule. This green one is the capsule of the kidney. Just beneath the capsule, these are stellate veins. Okay, stellate veins are present. Stellate veins are draining into interlobular vein, ultimately into interlobar vein. And this peritubular capillary plexus, they are again draining into this interlobular vein draining into arcuate vein draining into the interlobar vein, and then they are joining to form the renal vein. Okay, renal vein draining into the inferior vena cava directly. Okay, next. So you remember this flow chart. Renal artery, it is a lateral branch of abdominal aorta. In the dissection class, you have seen renal artery, and from the renal artery, it gives lobar artery. For each lobe or segment of the kidney, there are 5 segments in each kidney. Okay, one artery for each segment. Then from the lobar artery, it gives interlobar artery. Interlobar arteries are present in between the pyramids. From there, arcuate arteries are formed. From it gives branch interlobular artery. From here, afferent arteriole, then glomerular capillaries, then efferent arteriole. Now, this efferent arteriole in medulla, it is forming vasa recta, long loops. Okay, and in cortex, vasa recta, peritubular capillary plexuses are formed. This peritubular capillary plexus ultimately drains into interlobular veins, and the stellate vein from the capsule also drains into interlobular veins. From there into arcuate veins, into the interlobar veins, then into renal veins, and renal veins are draining into inferior vena cava. Okay, so this is the drainage system of kidney, blood supply of kidney. You have to write both the arteries, also the veins, and practice the previous diagram. Okay, this is a long question. Renal circulation is very important long question, also asked in your viva and histology also. Okay, next. Okay, so kidneys are supplied by the renal arteries. Usually there is one renal artery for each kidney. directly from the abdominal aorta. These are the renal arteries. And about 30% of individuals, accessory renal arteries are found. Okay, accessory renal arteries mainly supply this lower pole of the kidney. And renal arteries, they divide into anterior and posterior divisions. See here, this is the anterior view, here is posterior view. So this is anterior division, here you can see the posterior division. Okay, these are the different segments. Upper, this is the apical, upper, middle and lower. This view, you can, these four segments you can see from the anterior aspect of the kidney. And only one segment, posterior segment, you can be viewed from the posterior aspect of the kidney. So total 5 segments. Okay, and this is the division, lobar artery dividing, these are the pyramids lying within the medulla, and these are the cortex of the kidney. So this lobar artery dividing into interlobar artery, then dividing into arcuate artery, from there interlobular artery, from the afferent arterioles, okay, then glomerular capillary plexus. So these are the division of the renal artery. So the anterior division supplies the apical, upper, middle and lower segment, and posterior division supplies only the posterior segment, and the branches supplying the segments are called the segmental arteries. All these are, so 5 segments, so 5 segmental arteries are present in each kidney. Next, so abdominal aorta from renal arteries, segmental arteries. Segmental arteries are also known as lobar arteries. Okay? In the interlobar artery, arcuate artery, interlobular artery forms 5 to 8 capillaries. Okay? Afferent glomerular capillary plexus 5 to 8. Next. Now these are the vascular segments. According to Graves, on the basis of distribution of major branches of renal artery, each kidney is anatomically divided into 5 vascular segments, and each segment has its own artery, and between the segments there is no anastomosis. The segments are as follows. These are the 5 segments. Apical segment, it consists of medial side and the anterior part of the superior pole. Upper, it includes the remainder of the upper pole and the upper part of anterior aspect. Then middle includes the lower part of anterior aspect and lies between the upper and lower segments. Then lower, it consists of whole of the lower pole. Posterior consists of whole of the posterior aspect of the kidney between the apical and lower segments. The junction between the areas are supplied by the anterior and posterior divisions of the renal artery. It is called Brodell's line, and this is an important anatomical landmark. Okay, it is on the where is the Brodell's line? Brodell's line is important. It is avascular plane. Okay, here division occurs between anterior division and posterior division. So it is on the posterior aspect of the kidney at the junction of medial 2/3 and lateral 1/3. It is a functional avascular plane between the posterior segment medially and the upper and middle segments. Hence, it is suitable site for surgical incision to remove the renal stones, nephrolithotomy. For removal of renal stone, you have to go through this plane, Brodell's line, Brodell's plane. Okay. This is a avascular plane, that's why there is less chance of bleeding. Okay. In other area, if you cut, there is a rich vasculature, you have learned, rich vasculature for the kidney. Almost 25% of the cardiac output goes to the kidneys. Okay. So there will be heavy bleeding if you cut through other areas. Next. So these are the segments. See, this renal artery divides into anterior and posterior branch. Anterior branch dividing into 4 segmental arteries, apical, upper, middle and lower. This is anterior view, here is the posterior view, posterior segment. So this is lateral view, apical, upper, middle, lower, posterior. These are the 5 segments of the kidney. Okay. Next, Now we go to venous drainage. The venous blood from the kidneys is drained by the renal veins. Right and left renal veins are present. Lymphatic drainage. The lymphatic from the kidney drain into the para-aortic group of lymph nodes at the level of origin of renal arteries. What is the level of origin? It is also important. L2 level. Okay, L2. Nerve supply is kidney is supplied by the renal plexus of nerves which reach the kidney along the renal artery. And the renal plexus consists of both the sympathetic and parasympathetic fibers. And the sympathetic fibers are derived from T10 to L1 spinal segments, and parasympathetic fibers are derived from both the vagus nerves. Okay, so these are forming the nerve supply of kidney. Next, these are clinical aspects regarding the kidney. Floating kidney. Floating kidney is hypermobility of the kidney. The kidney is kept in position by the perirenal fat and the renal fossa. However, its kidney moves up and down with respiration, normally moves. Okay? And if the amount of perinephric fat is reduced, one fat pad is lying around the kidney. So if this fat pad is reduced, the mobility of kidney becomes excessive. That is known as floating kidney and may reduce the symptoms of renal colic caused by the kinking of the ureter. And a floating kidney can move up and down but not from side to side within the renal fossa. Okay, so movement is occurring only in up and down, not from side to side. Now, renal trauma. Kidneys are well protected by the lower ribs, lumbar muscle. A severe blunt injury of abdomen may crush the kidney against the last 11th or 12th ribs and the vertebral column. And the penetrating injuries are usually caused by stab injury or gunshot injuries. Since about 25% of cardiac output passes through the kidney, severe renal injury can lead to rapid blood loss. Okay, that's why it is important. And blood from the ruptured kidney or pass in a perirenal abscess first distends the renal fossa and then it trickles down within the fossal compartment and may reach the pelvis. Okay, so this is the direction. Next is transplantation of kidney. You have heard about transplantation of kidney, how it is done. It is done in chronic renal failure in selected cases when the renal function is heavily impaired. The donor kidney is placed. It is not placed in its original site. Okay, the donor kidney is placed retroperitoneally in the iliac fossa. Site is important. It is placed in the iliac fossa with hilum parallel to the external iliac vessel, and renal artery is anastomosed end to end to the internal iliac artery, and renal vein is anastomosed end to side to the external iliac vein, and the ureter is implanted into the urinary bladder. That is known as ureterocystostomy. Ureter is connected with urinary bladder for passage of urine. So this is transplantation of kidney. Next, okay, so blood supply of kidney is done. Next we will go to the ureter. Okay, we will discuss the ureter under this following heading. Next, so ureter, see, these are the kidney. From the kidney, ureters are arising and going downward to be drained into the urinary bladder. So here is the urinary bladder. So ureter, it is a thick-walled cylindrical fibromuscular tube and convey urine from corresponding kidney to the urinary bladder. Okay, this is the function. Next, so these are the functions of the urinary system. Kidney helps in formation of urine, ureter carrying of urine from kidney to the bladder, urinary bladder helps in storage of urine, and urethra voiding or elimination of urine. Okay. Next, so this is length and extent. Length is about 25 centimeter ureter. Diameter is about 3 millimeter. Extends from renal sinus. This distended part is known as the renal sinus. Renal sinus is a space within the pelvis of the renal sinus is a space within near the hilum of the kidney. Okay, where lies the pelvis of the ureter, renal vessels, different nerves and lymphatics. Okay, within the renal sinus. So ureter extends from renal sinus as pelvis of the ureter, passes downward and medially on the psoas major muscle. See, this is the psoas major muscle. Passes downward and medially on the psoas major muscle, crosses the pelvic brim. Here is the pelvic brim and enters into the pelvic cavity. Ends by opening into the lateral angle of urinary bladder. This is urinary bladder opening into the lateral angles of the urinary bladder. So this is the course. Next, three parts of ureters are present. Three parts are important. Okay, three parts and constrictions of ureter very frequently asked, and blood supply is important. From the blood supply, also explain why question is given. Okay, so three parts are present. Pelvis of the ureter up to lower end of the corresponding kidney. From the renal sinus up to this lower end of the corresponding kidney. This part is known as pelvis of the ureter. Then abdominal part from lower pole of the kidney up to the pelvic brim. Here, this part is abdominal part. And pelvic part, this part is pelvic part from pelvic brim to the urinary bladder. Okay, so these are the three parts of the ureter. Next, the extent has been written. Okay, so pelvis of the ureter, it is a funnel shaped dilatation of the upper part of ureter and it is formed within the renal sinus here by the union of major calyces. There are two major calyces here, 2 to 3 major calyces are present. They join to form the renal pelvis. The pelvis passes downward and medially through the hilum and is continuous with abdominal part of ureter at the level of lower end of corresponding kidney. Here it is the continuing downward as the abdominal part of the ureter. Capacity of the pelvis is about 5 to 7 ml. Next we go to abdominal part. It passes downward and slightly medially beneath the peritoneum of the posterior abdominal wall and enters the pelvic cavity by crossing the bifurcation of common iliac artery. Here is the bifurcation of common iliac artery into external internal iliac. At this region, ureter is crossing. Then pelvic part. At first, the ureter passes downward and beneath the peritoneum of the lateral pelvic wall and then passes obliquely to enter into the bladder. Here it is entering into the bladder. This part is the pelvic part. Okay, and near the pelvic brim, this part is lying. A junction between the abdominal part and pelvic part, where also the common iliac artery is dividing into external and internal iliac arteries. Next, now the course of the abdominal part, it passes downward and slightly medially beneath the peritoneum of the posterior abdominal wall, enters the pelvic cavity by crossing the common iliac artery and plaster to the parietal peritoneum. Okay, next, these are actually course and relation. Course of the pelvic part. See here, this is the pelvic brim is formed here. Okay, iliopubic eminence, arcuate line, all these are forming the pelvic brim. So the ureter passes along the anterior margin of greater sciatic notch. Here is the greater sciatic notch, passes along the anterior margin of greater sciatic notch, reaches the level of ischial spine. Here, ischial spine level, and this is known as first part or vertical part of the ureter. This pelvic part of ureter, it is also again divided into three parts. Okay, so this is first is the vertical part, then horizontal part, then will be the intramural part. Intramural part means that lies within the wall of the bladder. Okay, so first this is vertical part. which lies along the anterior margin of the greater sciatic notch, reaches the level of ischial spine, and this is known as first part or vertical part of ureter. From the ischial spine, the ureter passes forward and medially through the extraperitoneal tissue above the levator ani muscle and reaches the superolateral angle of the base of the urinary bladder at a distance of 5 cm from the opposite ureter, and this is known as the second or oblique part of the ureter. See, this is the second or oblique part. Next, then finally the ureter pierces the musculature of the bladder. See, here it is piercing the musculature of the bladder, undergoes an oblique submucosal course downward and medially. See, this is the submucosal course downward and medially through the bladder wall and opens into the interior of the bladder. Interior of the bladder, and this is known as third or intravesical part. Okay, that lies within the bladder wall, which is about 2 cm long, and the ureteric openings are about 2.5 cm apart when the bladder is empty. See, these two are the opening of the ureter, ureteric openings. Distance between these two is 2.5 cm. During empty bladder, distance is 2.5 cm, but the distance can be increased to about 5 cm when the bladder is distended. Okay. Next, next is the constriction. Constrictions are very frequently asked, very important. C comes in your OSPE if ureter is given in your OSPE question. Also comes in your short note in your theory paper. Okay. So constriction, 3 natural constrictions are present at the pelvic-ureteric junction, pelvis of ureter and abdominal part. Here is the pelvic-ureteric junction at the pelvic ring here near the where it crosses the common ilia and at the point of piercing the urinary bladder. It is the narrowest of all constriction, this third one, where it is piercing the bladder wall. Okay, that is also important MCQ. Which constriction is the narrowest? Okay, next. So how these constrictions are developing? Okay, this is you have to write if it comes as a short note constriction of the ureter. These constrictions are developmental rather than mechanical. Mechanical means due to pressure of other organs it is formed. But these constrictions are mainly developmental because the ureteric diverticunum presents two fusiform dilatations in the embryonic life, pelvic and lumbar dilatation. Okay, at the junction of these dilatation, constrictions are formed. Okay. Here are the ureters. Next, now the relations of the abdominal part of the ureter. Left ureter, this is on the left side, left ureter. Anterior relation is left gonadal vessels. This is gonadal vessels. Left colic vessels, left colic, sigmoid colon and mesocolon. And posterior relation is duodenum, terminal ileum, right colic, ileocolic vessels, right gonadal vessels, root of the mesentery. These are the relation. And for the right ureter, anterior relation is duodenum. See here, this is second part of duodenum. Terminal ileum, right colic, ileocolic arteries. Here is the right colic. Here is ileocolic arteries. Okay, gonadal, right gonadal vessel. This is gonadal vessel and root of the mesentery. These are forming anterior relation of right ureter. And posterior relation is right psoas major muscle, genitofemoral nerve, transverse process of lumbar vertebra and bifurcation of right common iliac artery. These are forming the posterior relation. Pelvic part also divided into 3 parts. First, vertical part, second, oblique or horizontal part, and third is intravesical part. So we will discussing first part or vertical part. First part forms the posterior boundary. This is vertical part. Here is the oblique part or horizontal part. and within the wall lies the intravesical part, third part. First part forms posterior boundary of ovarian fossa. See, this rounded area is the ovarian fossa. Ovary is lying here. Okay? And then it runs forward on the lateral fornix. This is the cervix of uterus and this is the fornix of the vagina. So then it runs forward on the lateral fornix of the vagina, 1.5 centimeter lateral to the cervix in female. Okay, so this is the relation. Next, above lower margin of the broad ligament. See, on the two sides of the uterus, these are the broad ligaments, and this is the section of ureter. So, lower margin of the broad ligament forming the above relation. Below there is levator aligned muscle. These are the levator aligned muscle lying below the ureter. Laterally, there is relation of ureter and uterine artery. This relation is important because it comes as explained why. Ureter is crossed above by the uterine artery from lateral to medial. See, this is uterine artery tortuous. Okay. It is crossing the ureter above the ureter from lateral to medial side. Okay. In this area, during bleeding during childbirth or due to any other reason trauma, if we have to ligate the uterine artery, we have to be careful because this ureter is lying in very close relation with this uterine artery. If you ligate the ureter, there will be blockage in urine flow, there will be development of hydroureter and hydronephrosis, okay, and kidney will be damaged. So you have to be careful during ligation of this uterine artery to prevent bleeding during parturition. See here the crossing. This is the uterine artery crossing the ureter above the ureter from lateral to medial side, and this is section through the cervix of the uteri. Okay, and these are the lateral ligaments helping keeping in position of the cervix. This is bladder. Here is cervix of uterus. This is rectum from anterior to posterior. Okay, and laterally, so medially there is supravaginal part of the cervix. This is supravaginal part of cervix lying medial to the ureter. Next relation of second part of the pelvic part of in male. Above and medially, see this is ureter are draining into the urinary bladder, and these are the vas deferens hooking above this ureter, and here it is formed the ampulla of the vas joining with the seminal vesicants forming the ejaculatory duct draining into the urethra in the prostatic part within the seminal calculus. So ureter is crossed above and medially by the vas deferens and below by the upper end of the seminal vesicle. Okay, this is seminal vesicle. Next, now this is one clinical aspect, vesico-ureteric reflex. Okay, what is this vesico-ureteric reflex? It is reflux. This is backflow of urine from the urinary bladder into the upper urinary tract, causing the following problems: transmits high bladder pressure to the kidneys. It is with leaking of urine. Okay, increased residual urine in the bladder with high chance of infection. Increased urine load in the ureter with stasis, stone formation in stagnant urine can occur, and risk of ascending infection to the kidneys, and secondary ureteropelvic obstruction due to infection and strictures can be formed. So these are the this can happen in vesico-ureteric reflux. Next, what are the factors present in our body which prevents this vesico-ureteric reflux? This is also an important clinical aspect, can come as a short note, vesico-ureteric reflux. Oblique submucosal force of the terminal intramural part of the ureter, where it is lying within the vesical wall of the urinary bladder. This course is oblique, so it will prevent reflux. Obliquity of the ureteric orifice maintained by contraction of the trigonal muscle. This is posterior view of bladder. This part is known as trigone of the bladder. Contraction of this muscle maintains the obliquity of the ureteric opening and also the obliquity of the submucosal course of the ureter. Ureteric peristalsis is present 2 to 5 per minute. It helps in drainage of urine towards the bladder. And pressure gradient, pressure in the lower part of ureter, that is about 30 centimeter of water, is more than in the intravesical pressure. Okay, intravesical pressure is 10 centimeter of water. So from the ureter, urine will drain into the bladder because all fluid is drained from high pressure to low pressure area. Next, so next, these are the histological structures of the wall of the ureter. It is outer from outside inward we are discussing. Outermost is fibrous coat. Outermost coat composed of mainly elastic fiber and is continuous with the renal capsule. This is the fibrous coat. Then there is muscle coat. In upper two-thirds of the ureter, two layers are present. Outer coat is circular, inner coat is longitudinal. Opposite to the gut. Gut, there is inner circular, outer longitudinal. But in urinary tract, there is outer circular, inner longitudinal. Okay. One extra layer outside outer longitudinal layers is added. Outer longitudinal, middle circular and innermost longitudinal. And no submucous coat is present in the ureter. That is also important. Mucous membrane, transitional, it is lined by transitional epithelium, is thrown into about 6 pores when the ureter is empty. See, these are the pores of the mucosa. That's why the lumen appears star-like. Okay, star-shaped lumen. Next. See, this is the star-shaped lumen. Here is a transitional epithelium. Transitional epithelium contains cells in multiple layers, each containing rounded nucleus. So, rounded nucleus in multiple layers within the mucosa for transitional epithelium. Then there is lamina propria. Then there is no submucosa is present. Then there will be muscular layer. Okay, inner longitudinal, outer circular layer of muscles, and outermost is the serous coat. Within serous coat, fibrous tissue, adipose tissue, some section of blood vessels you will see. So outer fibrous coat is known as adventitia. Muscular coat, upper two-thirds, contains outer circular, inner longitudinal layer. Lower one-third contains outermost longitudinal layer is added. And mucous coat is folded. Lumen is star-shaped. You can see star-shaped lumen. This is lumen lined by transitional epithelium. Okay. So this is the histological picture of ureter. Next is blood supply. Blood supply is very important. Okay. This is ureter. It is supplied by branch from the renal artery. This is branch from renal artery, branch from gonadal artery, lumbar arteries, branch from lumbar artery, internal iliac artery. Here is branch from the internal iliac artery, common iliac artery, obturator artery, and middle rectal artery, superior inferior vesical artery, and in female uterine and vaginal artery. All these arteries are giving branches to the ureter. Okay. Next, so how they are supplying branches? All these branches, they form a continuous arterial chain. Here is the chain is forming. All these branches dividing into ascending, descending branch and anastomosing with each other, forming a arterial chain. Ascending and descending branches of the arteries run in the fibrous coat of the ureter, form longitudinal anastomosis and plexuses. And therefore, and this comes as explained why. Therefore, stripping of the peritoneum during exposure of the ureter can endanger its blood supply. That's why stripping of peritoneum is not done. Venous drainage, veins correspond to the arteries, drain into the vena cava system. Okay, this is venous drainage. Next, Next is lymphatic drainage. These are the pre and para-aortic lymph nodes. Upper abdominal part to the lateral aortic group of lymph nodes. Lower abdominal part to common ilia group of lymph nodes. Here is the common ilia, and pelvic part to common ilia, external and internal ilia lymph nodes. Next, nerve supply, sympathetic and parasympathetic. Sympathetic via renal, gonadal, superior hypogastric plexus. Spinal segment is T10 to L1 and explains referred pain of uretary colic from loin to the groin. T10 and L1 segment, T10 to L1 segment. And genitofemoral nerve may be irritated in uretary colic, initiates the cremastery reflex. And parasympathetic derived from pelvic splanchnic nerve, that is S2 to S4 root palate. Next. Now how it develops? Ureter develops from stalk of ureteric diverticulum. See, these are the ureteric diverticulum or ureteric bud extending within the kidney. From here, the ureter is developing. Next, this is intravenous urogram, clinical aspect. Drug is given. Retrograde drug is there is a dye is pushed through the urethra into the urinary bladder, and dye is extending upward towards this pelvis of the ureter. And you can see the pelvis, the major and minor calyces, and the ureter and the urinary bladder. Okay. And also there is antegrade. In antegrade, intravenous dye is pushed and it will be drained by the kidney. And kidney, different parts of the kidney, major, minor calyces, ureter, urinary bladder, urethra, all will be visualized. Okay, so here is the minor calyx, then major calyx, pelvis, ureter, urinary bladder. Next. Now these are the clinical aspects of ureter. Ureteric colic, it may occur in ureteric calculi and pain radiates from loin to groin because T10 to L1 segments are involved. Hydroureter is dilatation of ureter and or calyces, minor and major calyces. Injury to the ureter may occur during hysterectomy. This comes as explain why. During hysterectomy, removal of the uterus at the crossing of ureter and uterine artery. That's why the relation was important. Left ureter has more chance of damage due to levo-rotation of cervix because cervix mainly lies mostly on the left side and ureter comes closer to the cervix. May result in ureterovaginal fistula, constant dribbling of urine per vagina. That is very difficult condition. Okay, you have to repair the fistula because there will be continuous dribbling because there is no sphincter in the vagina, so there will be continuous dribbling of urine through the vagina if there is fistula between ureter and vagina. Ureteric transplant to the urinary bladder or other organ like ileum or sigmoid colon can be done if it is accidentally cut during any surgery. Okay, it is anastomose with the bladder or ileum or sigmoid colon. Congenital anomalies like double ureter, postcaval ureter may be rarely seen. Next, stone in the urinary system. Ureteric stone. See, this is stone in the ureter near the bladder opening. May be impacted at the site of constriction of ureter, can be visualized by radiography, antegrade or retrograde pyelogram. Ureteric colic leads to severe pain due to distension of the ureter or spasm hits muscle due to presence of stones, strictures, kinks or compression, and the pain is sudden in onset, radiates from loin to groin, testis and penis, T12 to L1 segment. Next, hydroureter. See, there is distension of the ureter. This condition is characterized by distension of the renal pelvis, calyces and parenchyma with compromised renal function, usually due to an intermittent or partial obstruction to the flow of urine And unilateral hydronephrosis is due to ureteric obstruction, while bilateral hydronephrosis is due to obstruction at the level of bladder. Both the ureter will be dilated. At the level of urinary bladder, prostate or urethra. Next, congenital anomalies. Unilateral absence can be there. Okay, absence of ureter and one-sided kidney can also be present. Double ureter, here two ureters are present from this kidney. Congenital stenosis at the lower end of the ureter. These are the different congenital anomalies of ureter. Next, double pelvis, C2 pelvis are present. Premature division of ureteric bud, unilateral. Bifid ureter, this is bifid ureter, causes same, open through common as separate orifice, infection and stone formation is common. Megaloureter, this is bifid ureter, two opening, via two opening it is opening. Here is also ectopic ureteric orifice. One ureter is opening in bladder, another opening into the urethra directly. This is megaloureter. Unilateral or bilateral, absence of motility, prone to infection. A post-caval ureter, right-sided usually present, may be obstructed. Where the ureter is passing, generally it passes in front of the aorta and vena cava. And if it is present posterior to the inferior vena cava, that is known as post-caval ureter. And there is high chance of obstruction. Okay. Next. Okay, that's all. So clinical aspect comes as your embryology question. Ureter, for ureter, you prepare 3 parts of the ureter. Okay.
So yesterday I stopped at that slide. I discussed about hypoalbuminemia, and there are 2 modes of treatment which you will be practicing. The most cost-effective treatment for hypoalbuminemia for a poor patient will be egg albumin. There are very good preparations of albumin which are available that can be given, but in nephrotic syndrome, I told you there are 2 common causes of hypoalbuminemia. One is nephrotic syndrome, and the second one is advanced chronic liver disease. The pathogenesis or actual real cause of nephrotic syndrome is something different, where there is problem in the kidney nephron, or there is an inflammation and that needs to be reduced, for which steroids are used. And proteins do not play much role, because even if you give protein will be leaked. So it will not serve any purpose. So chronic liver diseases, in those cases, because the albumin level is low, if you give adequate amount of amino acids, that will be absorbed and liver will be able to synthesize albumin. And that is the basic reason why we give albumin. But the problem is that since the liver cells are diseased, that will not be able to produce adequate amount of glucose within a short span of time. And that's why there is another preparation of albumin which are of very high strength, that is of 20%. There are various strengths available, but most common strength is 20%. It is okay. এটা যাচ্ছে না কেন? See, this is none of the pictures that of my mother. She wanted to remain at her village home, and I kept 3 caregivers, but none of them looked at her. My sister came and found that her abdomen is swollen like this. And she sent this photograph in the evening, and the next morning I rushed simply to our house with an ambulance. And she was literally having both bones fractured, for which she was bedridden totally. And she was having an urinary incontinence. And this is the condition. Pointer to the so, so that was the picture. The abdomen was shining, and this is the evening picture was taken in the evening. And the next morning, I simply took her right to the ultrasonography room and got an USG done. And there is ascites. The amount of fluid will be about 5 liters. And the liver was portion granular, and immediately I made a diagnosis of cirrhosis of liver. And I got her admitted in the hospital, and the blood was drawn, and total protein was 5.5, and serum albumin was 2%. There is a huge amount of argument with our clinicians. They wanted to diagnose, the diagnosis provisionally to be a case of tuberculosis, which I denied, because the coarse appearance of granular liver is quite diagnostic of cirrhosis of liver. And this developed because of the chronic use of one drug, that is dihydronitrofurantoin, which was given for urinary incontinence. And you can see there are both bone fractured. So she could not literally move, and this is the degree of wastage. And this was her look. So they wanted to treat it otherwise. I opted for serum albumin because I had that knowledge that it will not increase the plasma albumin level so high, because from 2 milligram, 2%, if we want to rise it to 3% or 4, to reduce this swelling, it will take a considerable period of time, maybe 2 to 3 months also. Next slide. Next slide. যাচ্ছে না কেন, মুভ করছে না, এটা থেকে করবো, এখান থেকে করলে তো অসুবিধা হবে অনেকটা, এটা তো দেখতে হবে না। So next day, I gave 2 bottles of IV albumin, 20%. On next 2 days, can you see the size of the abdomen? It reduced. This much reduction is not possible with oral albumin. So I gave 3 bottles of IV albumin, and on the 8th day, that was her picture. She could somehow sit on the table, and I asked her to close the eyes to see whether she can really, stand stably. And on 15th day, that was her picture. She was at the age of 83.5 years. Unfortunately, she passed away after 6 months. So this is the amyloidosis is another part. Therefore, there is the impairment of. Why I have shown this picture? Because if you can treat your own family members with an adequate amount of knowledge, you will be really happy. And your family members will also be happy, because in this case, I could somehow straighten my mother within 3 days' time, because I knew the subject. I had that background that without serum albumin, this albumin level cannot be increased, and this ascites cannot be reversed. So otherwise, the abdomen would have not come down to this stage, and on 3rd, 4th day, 5th day, she could not sit it. And you can see the degree of improvement. So you must have that much strong amount of biochemistry knowledge to somehow modify whatever is written in the book. So amyloidosis is another. This is one disease. Just remember this thing. Not much of this thing. Just impairment of tissue function resulting from accumulation of insoluble protein precipitate in the interstitial places between cells. There will be several abnormal proteins, and that will be precipitated. One thing you remember, at least one is primary part. There is classification. There are many things which will be a lot, but primary is primary light chain immunoglobulin, which is synthesized, which is deposited in the between the interstitial space, and that causes amyloidosis. আরে এইরকম করে করতে গেলে তখন অনেক দেরি হয়ে যাবে। এখান থেকে করা যাবে? সেন্সারটা ঠিক করো, এরকম করলে তো মুশকিল আছে না ক্লাসে। Another part is clotting factors. So have you been told about this thing in the physiology class? You have been told. So you know this thing. So there are basically 12 clotting factors, and I did not then elaborate on these things. I will tell something else. So blood coagulation, that basically involves 12 coagulation factors, but there are 22 other factors which are also involved in the blood coagulation. And liver, the importance of liver here is that this 9 out of 12 clotting factors are synthesized by the liver. And you just make it a small note that except 3, 5, 4 and 8, these are not synthesized by the liver, but 8 is synthesized by the liver reticuloendothelial cells. So liver synthesizes 9 out of 12 clotting factors, including protein C, protein S, and antithrombin, which belong to these 22 others. So this is another catch question, multiple question, and this will be asked also during examination. What are the vitamin K dependent factors? There are 4 factors: factor 2, 7, 9, and 10. And what are their functions? You just note down this thing. This will be asked during examination. I have seen last time during the final examination. What does they do? They do hepatic gamma carboxylation. Basically, this is essential factor for hepatic gamma glutaminyl carboxylase that adds carboxyl group to glutamic acid of factor 2, factor 7, factor 9, and 10, as well as protein S, protein C, and protein Z. And when there is advanced liver disease, vitamin K injections are given only to increase these factors so that there is no incidence of bleeding or it is minimized. So vitamin K injections were not available during our time. Now it is available in many companies are producing this thing. So clotting, we have been told in the physiology class. I am not going into the detail. Common clotting factor deficiency disease, the commonest disease which you will see is hemophilia. Hemophilia A, that is due to factor 8 deficiency. Hemophilia B, that is due to factor 9 deficiency. And in India, there was a study in 2004 from Pune, and they estimated that it was supposed to be this total number of hemophilia patients in India was about detected cases. There are many undetected cases. About 11,586, and hemophilia B compared to that thing, it is 10 times less than hemophilia A, and there is another disease called von Willebrand disease. So just remember the most common clotting factor disorder is hemophilia, and hemophilia A constitutes the bulk. So this is a typical picture of I have taken from Durgapur Steel Plant Hospital. See, the patients are having a miserable condition. They are having with a trivial injury for which we don't bleed, but the hemophiliac patients do bleed. Can you see the picture? See the knee joint here is having hemarthrosis of the right knee. And if there is a chronic infection, bleeding, there will be joint deformities. That's why physiotherapy is done. And the person is in uniform, there is CSF. They are also exposed to several kinds of cases, and that causes bleeding. So bleeding from many sides is a real problem for hemophilia patients, and if there is an intracranial bleeding, that will be basically fatal and patient might die. Fortunately, that doesn't happen. Somehow the patient saved. That is saved. So this is another patient. This same patient. Can you see the picture? This left knee. So this is a real picture. This is from I have taken from our hospital. And the right knee again there is a hemarthrosis, a big hemarthrosis. The knee joint is supposed to exposed to injury, and the most difficult problem is the swath bleeding. Can you see the posture here? Can you see the swath muscle? If you recall the femoral triangle, from medial lateral to medial, iliac, swath pectineus, and adductor longus. So swath muscle, if it is damaged, there will be movement. The affected individual will not be able to flex his hip joint, and this causes real problem, compartmental syndrome. And this is hapless child. He has suffered so much within this tender period of such a younger age. So how can you treat these patients? So factor 8 has to be given because there is a patient is deficient in factor 8. So factor 8 injections are available. Government is kind enough to supply this thing, but the only thing is that if the person remains at a remote place, distant place, remote place, he has to come to that place to take that injection, and it is not always available. So that's a big problem. many companies are producing, so you will be also using vitamin, this factor 8. So if factor 8 is not available, then what can you do? So there is another called cryoprecipitate, that is formed from phase frozen plasma. That is very rich in fibrinogen, factor 8, factor 13, and von Willebrand factor. So basically, when this vitamin, this factor 8 injection is not available, then cryoprecipitate is given as a therapeutic measure to these patients, and hemophilia for patients is used as an emergency backup. For von Willebrand disease, normally this is not given, but the desmopressin is a drug of first choice. If there is a hypofibrinogenemia, that is also, in that case, this cryoprecipitate is given because the fibrin network will not be formed because there is a low level of fibrinogen. And bleeding from anticoagulation, cardiologists are very fond of giving very high doses of anticoagulant drugs to keep the blood fluid so that there is no heart attack. But in course of time, honestly speaking, most of the cardiac patients die from intracranial hemorrhage because of excessive anticoagulation therapy. So if even I am a victim of I must blame my cardiologist. They over-treated me, and I was supposed to have a bleeding. Somehow I stopped it. Everything. I had a bad, worse experience with these anticoagulants on me. So bleeding from excessive anticoagulation, that requires immediate control of the bleeding by cryoprecipitate. And there is another problem called disseminated intravascular coagulation, for which these cryoprecipitators are used. This can be formed, however, the phase frozen plasma has to be exposed to minus 60 degrees centigrade, and then that needs to be thawed slowly to 1 degree so that there will be visible precipitate at the end, at the bottom, and from that is collected and that is transfused. That is rich in clotting factors. So how to prevent occurrence of this troublesome, incurable somehow diseases with a poor quality of life? For all genetic diseases, this is applicable. We have to prevent the birth of affected child. What is the problem here? You see, this is the mode of approach for common genetic disorders. How to prevent? Because once the baby is born with affected child, you cannot kill the baby. That's a big problem. So there is an option there to prevent birth of the affected baby. How can you do it? You do it by prenatal diagnosis at the earliest. So if the baby is detected to be having a genetic disease, there is an option of the mother to undergo abortion before it becomes 12 weeks, maximum 20 weeks. So that baby will not be allowed to be born because that will be a burden to the total family, both the patient himself or herself and the family. The family will be literally ruined. I am telling you, the hemophiliac patients, the thalassemia patients, the parents, the conditions are miserable. So DNA testing from a somewhat invasive chorionic villus biopsy. Some part of chorionic villus has to be taken, a biopsy has to be taken, and the DNA has to be analyzed. Whether the DNA contains that affected gene or not. If that the gene is affected, then the disease is diagnosed, and there will be options will be given to the mother whether she wants the abortion or she wants to continue with the pregnancy. And I had an idea that for this test, I will be requiring one gynecologist and one sonologist. So can't I do it non-invasively? One of the non-invasive procedures is some blood, plasma, or serum. Fetal DNA is available in mother's blood as early as 5 weeks of pregnancy when the mother doesn't know that she is pregnant. So if the fetal DNA is available in the mother's blood, I can take mother's blood and do the DNA analysis and can detect. And with that objective, I went for a postdoctoral training at the famous postgraduate institute of Lucknow. I underwent a training to establish a DNA diagnostic center for Eastern India at Durgapur Children's Hospital and submitted a project to the government of India in 2002 May. And I was the principal investigator, and SGPJ additional professor wanted to be a co-investigator for the entire project because in Eastern India there is no such facility, and it was published in Hindustan Times both in English and Hindi version, and it is pasted at SGPJ notice board also. There is a big fanfare that SGPJ is going to set up a prenatal DNA diagnostic center at Durgapur at the back of city government of our hospital. But problem is that the government is thinks something and then they don't do. So my love labor was lost basically. The effort to establish a prenatal DNA diagnostic center of Eastern India at Durgapur Steel Plant did not see the light of the day because the government did not grant 22.5 lakhs rupees which I wanted for 3 years project. And basically my training went into the West. 22 years down the line, there is no such center in Eastern India for DNA diagnostic or the prenatal DNA diagnostic center. I had a dream to set up this thing, but shattered into pieces after 2 years when I realized that this will not be, I will not be successful. So I published my paper, what I wanted to do at Indian Journal of Medical Genetics in the year 2004. अरे बाबा तुम्हारे एकटाও কাজ করে না So this was a review article. This was the first paper, extensive review on cell-free DNA. This paper was published in the year 2004. That is a summary of what I wanted to do at our hospital. So coming back to antibody, now another part which is under plasma protein. Immunology, you have been told about immunology. You have been told immunology, so you know this thing. So antibody is basically where from antibody is produced? Last page, last one. Where from antibody is produced? You, last page. I am asking you, where from antibody is produced? Antibody, look at me. Where from antibody is produced? Which cells are responsible? And don't look at this thing, this answer is there. So you don't read. See, immunology has been covered. If you don't read, then you will not be able to understand. See, you are first and foremost, you are sitting at this thing and you will not be able to see this thing. So antibody is produced by the plasma cells, and these are differentiated B lymphocytes, and they recognize a particular part of the antigen that is called epitope. So antibody is basically a particular part of that antigen which is called epitope that is recognized by the antibody. Similarly, the whole of antibody doesn't bind to the antigen, it binds with one part, small part of the antibody that is called paratope. So this is just like a handshaking between a antigen antibody through epitopes and paratopes, and they determine the specificity of the immunological reaction. So natural body defense mechanism, we are having an innate immune system. See, suppose how can we say that we are immune to this thing? I think all of you are vaccinated with DPT, with polio. Unfortunately, during our time, this was not existent. When I was an MBBS student, in the early 80s, the vaccination, mass vaccination procedure started because we are immunized. What was given? Basically, a vaccine was given, and we developed antibody, and we developed immunity against certain diseases, common diseases. It can be given, it can be acquired also. We are exposed to many infections. day in, day out, we are exposed to a variety of bacterial, viral infections, and we do develop immunity because we have evolved over crores of years of evolution, and we are having all whatever antigens we have encountered, we are having a receptor, our body lymphocytes are having a receptor on it, and the moment the antigen enters, the body recognizes it. And if it is due to B cell or T cell immunity is mounted. So a person is said to be immune when he can mount an immune response sufficient not to suffer from that particular disease or particular infection. So active immunity will have two types. One is humoral. Humoral means related to body fluids, and one is cell mediated, that is mediated by the T cells. And humoral means body fluid, and most of the humoral immunity are conferred by immunoglobulin, and another part is complement system, but most important is immunoglobulin. So basic structure of an immunoglobulin, you must remember that there are two heavy chains and two light chains. The light chains will be either kappa or lambda, not a mixture of the two. That you must remember. So the basic structure is two heavy chains, two light chains, and there is a specific site called antigen binding site. So this is a minimum structure that is a monomer which are having two antigen binding sites. Means one molecule can bind two antigens. See, the whole part of the antibody doesn't bind, only a small part. This part is binding with the antibody, that is called paratope. So this is a monomer. So IgA can be a monomer, it is usually a dimer. IgM is pentamer. You must remember that IgM is a pentamer having 10 binding sites. That means it can bind 10 antigen at a time, and this is a very good agglutinating antibody. And this antibody of choice for agglutination reaction will be of IgM type, because they can cause visible clumping because of binding of so many antigens together. So the classification is based on basically the heavy chain. What kind of heavy chain is there? That is IgG. This you must be able to tell: IgG, IgA, IgM, IgD, and IgE, and that is due to the heavy chain which are named as gamma, alpha, mu, delta, and epsilon. Basically, I have classified them. I have them according to the serum concentration. The highest serum concentration is with IgG, and this is on the order of 1000. Now, IgG and IgD are usually monomer. IgA can exist as monomer, and mostly it is a dimer form, and that is the reason why the molecular weight you can see. Battery change karo. কোথায় গেলে ব্যাটারি চেঞ্জ করবে কেন? লাইটটাই জ্বলছে না। So this is 150. So why this it is 400? Because two molecules of that monomeric unit will be joined together with a joining chain. That's the reason why the molecular weight is 400. আটা আছে? And IgM, I told you it is a pentamer. That means 5 monomeric units are linked together with a J chain. That's why the molecular weight is 900. And IgD is again a monomer. IgE is a monomer. And the concentration is least at the IgE because this is allergy. So light chain you must remember it will be either lambda or either kappa or lambda, not a mixture of the two. না দেখো মজা রাখো এইরকম করে করলে তো ক্লাস এইগুলো তো দেখা করে কোথায় গেল আমি নিজেও বুঝতে পারছি না কোনটা একটা ভালো দাও কিবোর্ড আছে তোমার কাছে রয়েছে so if we go a little bit to the depth, that light chain region, this binding region, this variable part that is a hypervariable region is there, and there are three things, three dotted lines. You can see the dotted areas, and that is the reason why we get so many of diverse antibody in our body, and this structure is like this Y-shaped structure, and there is a hinge region for which it can operate like this. And there are three domains with the heavy chain. One is C1, C2 and C3, and the variable domain is like this. So this you must remember that the terminal part binds basically with the antigen. So how innumerable antibodies are formed? That is one big question, that we are having a limited number of genes, about 150 genes only, but the number of antibodies which you can produce will be nearly 1 million, that means 10 lakh. That is possible only by a variable combination, recombination of variable region, diversity region and the joining region. If you look at the variable portion of that antibody binding site, it is formed by the three genes, that is V, D and J, and that is called VDJ joining, and there will be innumerable combination of the three, and that is the basis of antibody diversity. And this came as a long question for me in 1990 in my MD examination as a under recent advances, because I knew that Sushma Tanaga was awarded Nobel Prize in the year 1988 and for this discovery of antibody diversity, that is VDJ recombination. And I expected this question also, because this is the most important part, why so many antibodies are produced. So this part, take a photograph if you require. You must remember this thing and show the rest of your life. And most of the things are covered here. You will not be required to know any more in detail, but at least whatever has been written in red letters, you must remember and you must understand. Let me tell you primarily, so when our body is exposed to infection or any kind of offending agent, we mount a response, immediate response, that is called primary response. And the primary response, the antibody responsible is IgM type. So when a recent infection is detected, that is basically of IgM type, and when any antibody of IgM type is detected, that indicates recent infection. And as I told you, because it can combine 10 antigens at a time, this is a very good agglutinating antibody, and it is also a complement fixing antibody. It can be produced by a fetus. That is another important point, because if a fetus is exposed to infection, that can mount a response by producing IgM. Being a very large molecular size, it cannot cross placenta. In contrast, once the person is exposed second time, person mounts the response, that is called IgG, that is of secondary response, and it always indicates that there is an old infection. So suppose there is a dengue infection, whether that dengue is of recent origin or it has happened earlier, the IgM type of antibody of dengue ELISA will indicate that this is a recent infection, but IgA type will indicate that he had an infection in the past for which the fever is there. So IgA gives a surface immunity in all our body secretions. IgA is there, and it confers immunity, local immunity. It absorbs the toxins, it absorbs the virus, bacteria, and doesn't allow it to pass through. It is present in all the body secretions, be it at the oral secretion, mucosa, oral mucosa, or gastrointestinal tract, vaginal fluid, prostatic fluid, any body fluids you can see, colostrum, milk, bronchial secretion, nasal mucosa, all IgA is present. IgD acts as an antigen receptor of the B lymphocyte. You must remember this part. IgA, most of the persons are allergic to something or other, and the antibody commonly prescribed for investigation is IgE. And if the IgE level is high, that means the person is having allergy in some form or other. And when the allergy is reduced, the IgE level also drops down. That's an important marker for immunity or allergy reaction. Only thing is that you can see the half-life is 2 2 days only. Here the half-life is 21 days because IgG is very important antibody which basically confers a good amount of immunity because it opsonizes bacteria, means it forms a coating around the bacteria so that the macrophage can engulf the offending agent or bacteria or parasite, whatever it is. So they can also engulf the bacteria and through a process of phagocytosis and can kill it, destroy it. So this is again to confer immunity to the growing fetus. It's the only class which can be transported across the placenta. That is one important point of IgG. And in the interstitial fluid, most of the antibodies are in the IgG type. Now, this will come as a question that is a spotter beep sure. Interpretation of serum electrophoresis and the M band. Yesterday, I told in detail about densitometric scanning. Once we made an electrophoresis, be it paper, be it gel, we get a densitometric scanning done, and we get, if we have the raw electrophoresis, be it paper, be it gel, and if we stain it, it will look like this. And if we make a densitometric scanning, we will get a curve like this. And for albumin, we will see the highest peak here. This will be close to anode, that is positive pole, and this is a normal electrophotogram. So normally what happens in a laboratory, multiple samples are run together in one chamber. See, in one electrophoresis today we have collected, or maybe in this week we have collected some 10 samples, and that will be run simultaneously. And we have to interpret based on this picture. And you see here, see this row, this row, this row, where the arrow has been given, this picture is almost same. And that is a normal type of electrophoresis. In contrast, you can see here there is a broad band that is called beta myeloma. And this is again, there is a problem here, and we see this area is wide. So this you note down that beta gamma bridging is the characteristics of cirrhosis of liver, because there is more synthesis of beta and gamma globulin. Just note down this point. Beta gamma, what is beta gamma bridging? That is characteristics of cirrhosis of liver, more synthesis of beta and gamma globulin. So multiple myeloma, concentrate on this thing because this is a question, I must say. So multiple myeloma patient you will see in your clinical years. At least I have seen several cases. So multiple myeloma is a plasma cell tumor cancer, and since this is a cancer, it is not having a control, just like a normal cell. So it produces abnormal antibody. So that abnormal antibody being produced in very high concentration will cause a hyperviscosity syndrome. Plasma will be viscous, and there will be abnormal immune function, and a single clone of cells will produce antibody. That's why it will cause monoclonal gammopathy. Only when one tumor is present, that is called plasmacytoma. When multiple areas are involved, that is called multiple myeloma. And in the question also, I have seen that write down the clinical features. So remember crab, that will be the mnemonic. There is hypercalcemia, renal failure, anemia, and bone disease. And there will be multiple punched out lesions. And once you diagnose, see the X-ray picture, you will be able to diagnose primarily that this is a case of multiple myeloma until proved otherwise. I repeat, until proved otherwise. Multiple punched out lesion on the bone is characteristic of multiple myeloma, and biochemical diagnosis will be made. This will be a confirmatory diagnosis. Clinically, you cannot make a diagnosis. You can suspect, but the confirmation will rest on diagnosis of paraproteinemia. That is M band in electrophoresis or base-joint protein, which I could not see in my 30 years of life. A single case of base-joint protein I could not detect it. But M band in electrophoresis I have seen, and it is quite visible that is diagnostic. You have seen this thing. So the albumin being present in the highest concentration, it is the produces thickest band. And you can see here there is a beta myeloma. Beta band, close to beta band, there is a very thick concentration, and correspondingly you can see the peak also densitometric scanning. In the strip itself or in the gel itself, we will be able to diagnose whether it is a beta myeloma or whether it is gamma myeloma. And this is another picture that it is typically M band is located nearly beta, and massive amount of low molecular weight immunoglobulin has been posed, and that is quite characteristic of multiple myeloma. This strip will be given, and examination will ask what condition, what is this thing, and what is your interpretation. So M band, what is M band? It is a myeloma protein, basically. Top sentence, the myeloma protein results from monoclonal proliferation of plasma cells, and there are many, this is an abnormal immunoglobulin. It more often formed of a IgG light chain in excess amount. Since this is produced in excess amount, that's why that area is showing a very thick or dense staining area. This area is staining area. This area, you can see that there is a excessive amount of this particular protein is produced. So the other terms are monoclonal protein, M protein, M. Just remember M protein. So why M protein is deleterious? Because this is present in excess amount. So there will be impaired immune response. This is not a normal immunoglobulin. So it will not allow the other immunoglobulins to function. So because of its huge amount of presence, huge high concentration of presence in the plasma, immunity will be severely compromised, and there will be blood will be of highly viscous. It will cause thick blood, and that will also cause kidney damage. So you can see the peak. If you make a densitometric scanning, can you see the peak here which I have shown? So that you must remember that this staining or this particular band in this region apart from the albumin region. So Baines-Jones protein is a very characteristic of multiple myeloma until proved otherwise. This is one condition which is called, that is Waldenstone macroglobulinemia, but that is not common. So in this case, what is Baines-Jones protein? Normally protein doesn't appear in the urine, or it is present in a very small amount, maybe 150 microgram per 24 hours. But this light chain protein, the lower molecular weight, that is 22 to 24 kilodalton, and because of this low molecular size of protein, this light chain protein passes through the urine, and this can be detected. You must remember this property of Baines-Jones protein. It is not found in other proteins. Normally, when the protein is heated, the protein is coagulated at a high temperature, and once it is coagulated, no renaturation is possible. That is an irreversible process. But here the peculiar special property of precipitation at 40 to 60 degrees temperature, when the albumin doesn't get precipitated, but the protein residuals at boiling point. It's a peculiar thing. At boiling point, the egg albumin becomes totally white, and subsequently cooling, it will reprecipitate again, and again boiling will dissolve. And this sequence can be repeated many times. On cooling to room temperature only, they will be precipitate, and that is the characteristic of protein. Unfortunately, I have done several cases of dealt with multiple myeloma cases in my professional life, but I could not detect a single case of Baines-Jones protein. The reason is that test is not that very sensitive. Now today we are having electrophoresis, or that is immunofixation electrophoresis of concentrated urine or serum light chain immunoassay to detect this diagnosis condition. Because once a patient is diagnosed to be having multiple myeloma, this patient requires monitoring, that whether the patient is responding to therapy or not. That will be detected only by the lowering of this Baines-Jones protein or that particular abnormal protein which was present in the excess amount, very high amount at the time of diagnosis, and subsequent treatment, success or treatment will depend mainly on the level of this paraprotein which was increased for the disease. So these three types of different types of electrophoresis you will get. One will be you will get a normal pattern. One will indicate some amount of inflammatory. You can see the alpha globulin, beta globulin is there, and also a little bit of gamma globulin that is of inflammatory region. But multiple myeloma, there is a typical peak at the gamma region. This is the immunoglobulin type, or you can see it at the beta position also. Another part which this is a single slide I have shown just because the immunity has been covered. So there is a protective part of which is also a complement system that is also comes under the purview of plasma protein, and this is another part of humoral immunity, just like immunoglobulin. That is a cascade of protein also. It is just like coagulation, it gets activated, and the cascade of protein, the complement factors are from C1 to C9. Basic purpose of this complement system is to trigger membrane attack of the affected cells, be it bacteria, be it virus, or be it an affected cell, phagocytosis and inflammation. And this is activated on exposure to an antibody complex. One slide, this you will again advise in all patients undergoing inflammation. So acute phase proteins, acute fast proteins, in response to inflammation due to any cause, I repeat, the concentration of a class of protein in the blood either increases or decreases. When it is an increase, that is called acute phase protein, and C-reactive protein you will do it almost in every cases to monitor the progress of the disease, whether the patient is responding to treatment or not. There are other complement factors, acute phase proteins, but these are not really done. These are done for some other purposes, but these levels are also increased. In contrast, there is a decrease also of the subproteins. The most important part is albumin, which I have also told. So this is an acute phase protein. What is acute phase protein? In response, you should remember this thing. In response to inflammation, the concentration of a class of proteins known as acute phase proteins level changes. The basic purpose is to destroy or inhibit the growth of the microbe or to reduce inflammation. So C-reactive protein is produced again by the liver. Its concentration is increased in plasma and increased response to inflammation. Inflammation can be caused per se by an immunological reaction, by any means. Even a physical injury can cause inflammation. Other causes of inflammation are infection, trauma, necrosis, malignancy, and allergy. Any cause of inflammation, you will get a C-reactive protein increase. Now, commonly it is done for infection because you know that there is a trauma, you know the history that there is a trauma, you can monitor the trauma. Necrosis you cannot always diagnose, but most common indications of C-reactive protein is active infection. It is so named because it originally bound to the C polysaccharide of pneumococcal. Just write down this thing. What does the C-reactive protein do? It is to bind the lyso or some type of bacteria in order to activate the complement system, and that is the function of C-reactive protein. So normal level of blood is very low, that is 0.8 to 3 milligram in adults. Because of chronic exposures of infections, its level might rise even to 10 milligram %. A CRP level, when it increases about any time more than 10 times, you can see that there will be an infection, and if the infection is severe, it can go to 10,000 times, as this milligram will be really increased at 6 hours, and they will be picking up at 48 hours, and its plasma half-life is 19 hours. So, the basic purpose is of showing this thing that the level is here is 0 to 3, 0.8 to 3, but if the CRP level is between 10 to 100 to 500, it is considered a bacterial infection. So, in bacterial infection, which is a common problem in clinical practice, CRP level will be increased, and this, once you control with antibiotic, again this level will fall down, because it is having a half-life of 19 hours only. So, it will come down within 2 days time once the infection is controlled. So, again I told you, once the inflammation subsides, CRP level also falls rapidly. So, one highly sensitive CRP is there, you will read it in detail in your microbiology class, and when in excess of 3 milligram, that can detect a cardiovascular risk, whereas below 1 milligram, there will be practically no risk. That is one thing that cardiologists say, but your main emphasis will be to monitor the infection. I think we have come to an end, because you see, I started with this slide, because in plasma, apart from this thing, a number of substances are present and which can be measured. The topic is endless, and the biochemology, biochemistry department are resting and catching on this detection of abnormal concentrations from blood or plasma. I will read this topic thoroughly, and whatever is left, whatever you cannot understand, we discuss in the small group discussion. And I will be taking a small group discussion on this topic. Maybe I will cover some of the things in 1 hour time, and 1 hour leave for discussion during that small group discussion. So, I think I have completed in time. So, you enjoy your class rest of the time.
So, we are continuing with this microanatomy and entering to the nervous system. Of the nervous system, central and peripheral nervous system, we have 3 microanatomies of organs to study. One is the spinal cord, which we are going to do today, and later on we have the cerebrum and cerebellum. Along with, we have this slide of eyeball, then that will be covered as well. So, these are the 4 content of the central or peripheral neural organ that we are going to cover. Now, in the central nervous system, we are going to talk about the spinal cord, which is the gross anatomy is kind of like we know that so far our 10+2 knowledge is concerned, which is a cylindrical tube continuations of the brain, lies in the vertebral column, hangs down from the foramen from the brain. We call them as middle oblong, which is known as foramen magnum, going down as a continuation of the brain stems, goes through this particular spinal cord, spinal canal through the vertebrae, and ends at the point we call them as phylum terminal, which is a lower end of this particular spinal cord, along with the covering, which is known as this meninges. Now, if you make a cross sections of the spinal cord, it is composed of the 2 elements that we are going to see. One is the central element, we call them as gray matter, which is composing of the neural cells or cell bodies, and we have the surrounding tissues, we call them as white matters or white tissues, which is surrounding this particular gray matter, which is composing of these filaments, which is coming from these neurons. That means the axons and the dendrons, they are composing and constituting the peripheral subject, which is known as the white matter. Now, apart from this particular neural tissue, which is composed of the 2 element, we call them as gray matter and white matter, we have a central canal which is running and piercing through the entire length of the spinal cord. We call them as central canal of the spinal cord. Now, the central canal of the spinal cord may not be significant whenever you are studying this particular in a gross anatomy, but when we are studying this particular microanatomy, the central canal is the utmost important for us, because we focus through the central canal. So, the central canal, which is a continuation of the central nervous system, ventricle system. So, inside the brain, we have a cavity inside. We call them as ventricles of the brain. There are several ventricles or the chambers or cavities are there, just like chambers in the heart we have. Now, this particular ventricle system which is present in this particular brain main content, we call them as cerebrum, cerebellum and as well as brainstem, is continued down to the spinal cord as well as a narrow slit. That particular central canal which runs throughout the entire length of the spinal cord, which is lined by a flat columnar cells. So, single layer flat columnar cells which is little bit modified in the central nervous system. We give a special name to it, we call them as ependyma cell. So, that particular ependyma cell is a modified flat columnar epithelium which might have cilia on top of it. So, that particular central canal which is lined by this particular single row of these cells, epithelium cells, we call them as ependyma cells, which is a hallmark that we are going to identify the spinal cord with. Once you identify that particular canal, any circle, that particular circle is covered by this particular single layer cells which is the columnar to cuboidal cells, which is may have a cilia to it. Next to it, periphery to it, we have this particular dispositions of the gray matter, and then afterwards we have this white matter. So, this is how whenever you are judging this microanatomy, we will be focusing on the narrow foramen. Similar to that, whenever you studied this particular liver microanatomy, so we focus around the central canal or central vein. That particular central vein, from that we have the radiating cells of the hexagonal hepatocytes radiating towards different directions. So, similar to that, we focus this particular microanatomical structures of the spinal cord based on this particular central canal which is lined by the ependyma cell. We have to identify that, and on margin of it or peripheral to it, we have this particular gray matter and then we have the white matter. So, this is how we are going to identify. So, this is the logic of identifying the central nervous system, and this is what we are going to identify. So, this is the spinal cord that we are seeing here. The spinal cord central part, we have this particular cell bodies of the neurons lodged in here. We call them as this region, we call them as gray matter. This is relatively less stained, we call them as relatively stained, we call them as gray matter. And then we have this particular white matter surrounding to it. This white matter, which is this region and as well as these regions, is made of or composed of neuronal fibers, which is made of these white fibers, of course, because of this myelination, and these are known as action dendrons which are present in it. This region we have the cell bodies. If you have cell bodies, the nucleus will be there. So, these are the nucleus which is present in it. So, these neural cell bodies are there. Now, if you just like look at this particular orientations of this particular cell body of the spinal cord, it has a particular pattern. We have called this as a H-shaped pattern. It looks like the English letter H, which is having two limbs, vertical and a horizontal limb penetrating or joining together. So, this particular H pattern which is present of this particular gray matter in this particular spinal cord is very much visible and very much identifiable. But whenever you are going to see this microanatomy, we cannot see this particular whole sections at a time because it is too big. We are narrowing it down, focusing it down. Whenever you are focusing it down, we will be focusing around this slit that we are referring to. So, we have to identify this narrow slit where I am putting the cursor on. This slit which is present in the middle of this particular horizontal limb of this particular gray matter, we call them as central canal, this hole. Surrounding the central canal, we have this particular cells, we call them as ependyma cells, which is simple column kind of cells, cuboidal column, maybe ciliated kind of epithelium, which is single layer. So, it's kind of cells which is lining here, which is making this particular hole very discrete, just like it's look like it bordering this central canal. So, once you have this particular central canal, which is covered by this particular ependyma cells, which is simple columnar kind of epithelium, which may be ciliated. We are not going to see the details of the cells whenever you are looking at. But again, once you see this, next to it, we will be seeing the dispositions of the gray matter. These are the gray matter cells. And then farther down, we see this particular white matter where this thing ends. Now, we see that the pattern of this particular thing, which you were saying macroscopically, when you were seeing this particular in a less zoom manner, this particular gray matter has a dispositions like English letter H, and it has two limbs. One is having directed anteriorly, one is directed backwards. So, this particular limbs which you see here, we call them as horns. So, this is one horn, this is another horn. So, if this particular side is anterior side, we call them as anterior horn. This is, if it is a posterior side, we call them as posterior horn. So, these are the horns or gray matter horns. This particular gray matter horns, as you are seeing here, where you see this particular little bit thickened, the anterior horn is there, whereas little bit narrow or tapered, these particular posterior horns are there. There are two such horns are there on the posterior side, right and left, and two such horns are there in this back side, in the front side, right and left. And in between them, we have the bridging tissue, which is the same gray matter tissues which is present in it. So, this is how the sections of this particular histological anatomy of the spinal cord looks like. Now, I am not going to talk the detail of this particular histological orientations of the gray matter cells, how these horns are composed of, what kind of cells are lying in there. Those are the theoretical concern. Now, I am not bringing them. So, whatever the content is relevant to learn this microanatomy, that's the only part I am just talking here. So, this is the real picture that you are going to see, and again you cannot see this particular whole picture that you are seeing here. This is the whole spinal cord along with this gray matter, white matter and the central ependyma. You cannot see this particular element. So, what you can see, this particular element, we call them as central canal. Surrounding the central canal, we have these pygnotic cells, which is the single layer, one layer, columnar to cuboidal kind of epithelium, which may be ciliated present in it. So, this particular cells, which is present in here, around this particular central canal, that is what we are going to identify it. Now, this particular central canal, majority of the time we see that it looks like a diamond, it is kind of diamond shaped or it is a kind of like square shaped rather than it is a circular canal. So, you will see that this particular thing, whenever you are seeing this particular anatomically, microanatomically in the microscopes, this particular central canal is not exactly the circular, rather than it has a diamond pattern or just like rhomboid shaped structures. So, this is the orientations, gray matter, white matter, what theoretically you should be knowing and how this particular gray matter and white matter is disposed of. But for us, this particular hole or slit is the hallmark to identify whenever you are identifying this tissue, whenever you are seeing that microscopically. So, this particular element helps us to identify this microanatomy of this particular spinal cord. This is a very, very small precise thing that you are going to identify. This particular microscopes are fitted with this particular spinal cord. So, whenever you are going to see this particular spinal cord, try to identify this particular foramen. We have placed this particular thing around this particular foramen, which is known as central canal. Surrounding the central canal, which have a single layer cell surrounding to it, which is an ependyma cell, which is the hallmark to identify. Now, again, this particular central canal is not a circular canal, it may be rhomboid shaped, that means it may be diamond shaped, which may be looking like a diamond shaped structure there. Once you see this particular central canal, if you look little bit on the outer side or the sides or margins of it, you will be finding the gray matter it is disposed of. And if you move this particular slide, if you move farther away towards the periphery, you will see this particular gray matter which is staining little bit pink will be fading off and will be becoming less faded, which is the white matter it is composed of. So, to summarize about microanatomy of this spinal cord, first thing first, we have to identify the central canal. The central canal is the same ventricular system which is present in the brain, spinal cord, brain, cerebellum, etc., all these things which is continued down to the spinal cord, which is a narrow slit. Through this particular central canal, the CSF should be flowing through it, but no such flow happens to occur, but the slit remains. So, this particular slit which you are seeing here is guarded or covered by a single layer cells, we call them as ependyma cells. How does this cell look like? If you see them, it is a single layer cells, and these cells usually columnar to cuboidal cells, and they may have cilia on top of it. This is how, if you zoom and super zoom it, you can identify it. Now, surrounding this particular central canal, we have a dispositions of the gray matter, which is the cell body of the neuron cells. If you move farther away towards this particular margin, you might see this particular element, which is the white matter. The gray matter and the white matter are composed of the two structural difference elements of the neural cells. Neurons have got two elements, it has cell bodies and it has projections. Those projections we call them as actions and the dendrons, which are kind of connective channels between these adjacents and nearby father neurons. So, that particular connections or the thread like projections which is coming from these neurons, we call them as axons and dendrons depending on the lengths, and they are connecting and traveling through this particular entire spinal cord system and as well as brain, cerebellum, etc., etc. So, that particular white matter which is composed of the myelinated, which is composed of this particular myelin sheath which is white, that is why we call them as white matter fiber system which is present, which is nothing but the axons and the dendrons of these neurons which is running through, whereas the cell bodies where the nucleus and everything organelles are present are housed inside this particular gray matter. Now, this particular gray matter in the spinal cord has a particular pattern of look like, we call them as H-shaped structures. It has two limbs, anterior horn, posterior horn, and it has a central canal in between. So, this particular anterior horn and posterior horn, these are kind of like a universal present in throughout the length of the spinal cord. In some segments of the spinal cord, we may have some additional horn present, we call them as lateral horn. So, if you have this posterior horn and anterior horn, in between them if you have a bulged up tissue, we call them as the lateral horn of this gray matter which is present in particular segment of the spinal cord. But again, I am not complicating all those neural tissue content right now, only just focusing in this particular prime content of the spinal cord as far as identifying the spinal cord is concerned. So, whenever you are identifying the tissue, you will identifying the central canal which is covered by this or lined by this particular ependymal cells. Then next we have this particular gray matter and white matter. The gray matter out here is present to this particular, next to this particular central canal, has a particular H pattern which has anterior limb and posterior limb, and this particular white matter is present in the farther periphery which composed of the myelinated neural fibers which is axons and the dendrons. So, these are the three identifying features of this particular spinal cord you are seeing here. Further on this particular neural tissue, when we will be starting the detail of it, we will be discussing about anterior horn, posterior horn, lateral horns, the different segments of the spinal cord, spinal nerves, etc., later on. So, till now this much we are going to talk. So, we have 4 or 3 slides which has this particular spinal cord end. Try to focus in which are focused on the central canal surrounding this particular ependymal cell, identify them, and then we are finding the contrast with this gray matter and white matter in this particular, as we move from the central to periphery, you will see this particular gray matter and then white matter, how it is composed of. Okay?
So, the graph is so this is abdominal aorta. These are the 3 ventral branches. Silence everyone. These are the 3 ventral branches: ciliary trunk, superior mesenteric artery and inferior mesenteric artery. So the gut is supplied by 3 ventral branches of abdominal aorta, which are ciliary trunk, superior mesenteric and inferior mesenteric arteries. Embryologically, the ciliary trunk is artery of foregut, superior mesenteric artery is artery of midgut, and inferior mesenteric artery is artery of the hindgut. Okay. Next. Okay. So superior mesentery is artery of the midgut. So which structures it will supply? Superior mesenteric artery of midgut, it supplies these structures. Part of duodenum distal to the opening of bile duct. That is distal to the mid part of the second part of duodenum. Okay, distal to ampulla of butter or major duodenal papilla. Then jejunum, ileum, cecum, appendix, right 2/3 of the transverse colon, lower part of the head of pancreas and its uncinate process. All these are supplied by the superior mesenteric artery. How it begins? It arises from the front of aorta behind the body of pancreas at the level of L1 vertebra, and it arises about 1 centimeter below the celiac trunk. So this is the beginning of superior mesenteric artery. Vertebral level is L1, you have to remember, and 1 centimeter below the celiac trunk. Next is the course. See, this is superior mesenteric artery. It runs downward, forward and to the right here. downward, forward and to the right in front of uncinate process of pancreas, and further it crosses the third part of the duodenum anteriorly to enter the mesentery, and then it runs in between the two layers of the mesentery towards the right iliac fossa. Okay. So yesterday we have seen the mesentery and the superior mesenteric artery was entering the mesentery. How it terminates? It terminates in the right iliac fossa here by anastomosing with the branch of iliocolic. Okay. This is iliocolic, the descending branch of iliocolic, anastomosis with the terminal branch of this superior mesenteric artery. What are the relations above the root of the mesentery? Relations are anteriorly there is body of pancreas and splenic vein. Posteriorly, aorta, left renal vein, and uncinate process of pancreas and third part of duodenum within the root of mesentery. And it runs into two layers of peritoneum accompanied by superior mesenteric vein on its right side. Next, see the relation. See, this is the head, neck, body and tail of the pancreas. Tail is entering into the hilum of the spleen. Along the upper margin of the body of pancreas, this tortuous splenic artery is going, which is a branch from the celiac trunk. See, this is celiac trunk, three branches, left gastric, common hepatic, and this is splenic. And 1 centimeter below, just behind the body of pancreas at L1 level, superior mesenteric artery is arising. Okay, its first branch is inferior pancreatico-duodenal. It is also dividing into anterior and posterior branches, anastomosing with the superior pancreatico-duodenal and supplying the head uncinate process of the pancreas and the duodenum. Okay. After that, it is giving other branches. And see here, the superior mesenteric artery, it is passing in front of this uncinate process and in front of this third part of the duodenum. Okay. On the right side, it gives the colic branches, and on the left side, these are the 8 to 10 almost jejunum, branches for jejunum and ileum. Okay. Next, see, inferior pancreatico-duodenal has been shown, and here this is inferior mesenteric artery. Okay, superior mesenteric, here is the position of inferior mesenteric, which arises at A3 level. Okay, deep to this third part of this duodenum. Okay, and these are the jejunal arteries has been shown. Next, see, celiac trunk, different parts of duodenum, colon, two kidneys, suprarenal gland, ureter. This is superior mesenteric artery and is the inferior mesenteric artery. Okay. Next, see, these are the branches. Silence everyone. কি হচ্ছে কিছু অসুবিধা হচ্ছে বুঝতে? কি এত কথা বলছিস তখন থেকে? Okay, from the right side, it is giving first branch is inferior pancreatico-duodenal. Next, from the right side, colic branches, middle colic artery, then right colic artery, then ileocolic artery. Okay, and on the left side, it is giving branches, jejunal arteries and ileal arteries. Okay, all these arteries are dividing into two branches and forming loops. Okay, and vasa rectors are extending from these loops of arteries to supply the small intestine. Okay. Now you see this middle colic artery, it is again divided into two branches. One is right branch, one is left branch. Left branch anastomosing with the ascending branch of left colic, and this right branch anastomosing with the ascending branch of right colic artery. Right colic artery, it is dividing into ascending and descending branch. Ascending branch anastomosing with middle colic, branch of middle colic, right branch, and descending branch is anastomosing with ascending branch of this ileocolic artery. Okay, so all these arteries together forming a anastomosis. Okay, that is known as marginal artery of Drummond. Okay, and from this marginal artery, vasa recta. These are the vasa recta. These are going to supply the colon. Okay. From the ileocolic, one important artery is given, that is known as the, from the descending branch of ileocolic, you can see two branches, anterior and posterior cecal arteries, and another is appendicular artery. Appendicular artery is going along the free border of the mesoappendix and supplying the appendix. Okay, and tip of the appendix is getting less supply. That's why necrosis or inflammation occurs mainly at near the tip of the appendix. And these are the jejunal and ileal branches, almost 8 to 10 in number, giving branches, forming the loops and windows, and from the windows are less in number near the jejunum and more in number towards the ileum. See, these are the windows, forming anastomosis and forming windows. And here the windows are less, so vasa rectas are long. But for ileum, windows are more in number and vasa rectas are shorter in length. Okay, you can differentiate. That's how you can differentiate jejunum and ileum. Okay. See, these are the jejunal branches. Here are the ileal branches, has been shown. So jejunal branches, they are also forming loops and anastomosing with each other. Mainly 1 to 2 windows are formed at this level. And the vasa rectas are extending from the terminal loop. So vasa rectas will be more length, longer. And in the ileal region, 3 to 4 windows are formed. Okay? So from the terminal loop, vasa recta will go to the ileum, and the length of the vasa recta will be less. Okay, lesser than the jejunum. Okay, understood? Okay, next. See here. This is superior mesenteric artery. Here is the middle collic. Here is the right collic. Here is ileocolic. From the ileocolic, cecal branches, appendicular branches. These are the jejunal and ileal branches entering into the mesentery and supplying the jejunum and ileum. Okay. Okay, next. এখানে আছে দেখাচ্ছি দেখুন. This is ileocolic artery. It is giving one ascending branch, one descending branch. Okay. Ascending branch will anastomose with descending branch of right collic. And descending branch, it is giving two cecal branches. Anterior cecal or posteriorly যেটা যাচ্ছে posterior cecal. And this one is the appendicular branch. This one, mainly from this posterior cecal. This run along this mesoappendix. There is a peritoneal cord suspending the appendix, that is known as mesoappendix. That runs along the free border of the mesoappendix and supplying along the length of the appendix. Okay, তাহলে বুঝতে পেরেছি appendicular branch. Okay, this is one ileal branch. Next. So these are the branches. We discuss the branches in details. Okay. Inferior pancreaticoduodenal artery divides into anterior and posterior branches, lies in the groove between the duodenum and the head of the pancreas. The middle colic artery is divided into right and left branch. Right colic artery divided into ascending, descending branch. Ileocolic artery, it divides into superior branch and inferior branch. Here is superior, here is inferior. Inferior branch, ascending colic branch, anterior and posterior cecal branches, appendicular artery, and iliac branch. So these are the branches from the inferior branch. Then there are jejunal and ileal branches, 12 to 15 in number, and they are forming the vasa recta. Okay. Next. So beginning branch, it is a branch of abdominal aorta, L1 level. Force runs over the uncinate process of pancreas to enter the mesentery, terminate by anastomosing with the branch of ileocolic in the right iliac fossa. Branches are these 5 branches mainly.
inferior pancreaticoduodenal, middle colic, right colic, iliocolic, jejunal and ilial branches. Okay, so all these are branches from superior mesenteric artery. Next, so individual branch we will discuss. Inferior pancreaticoduodenal, this one. Okay, it is the first branch of superior mesenteric artery, arises on the right of the superior mesenteric artery at the upper border of third part of duodenum. Divides into anterior and posterior branches which run in the pancreaticoduodenal groove, and it supplies the uncinate process and lower part of the head of pancreas and duodenum. Ends by anastomosis with corresponding branches of superior pancreaticoduodenum. That was branch from gastroduodenal artery. Okay, next. Next is middle colic artery. This one is middle colic. Arises from the right of the superior mesenteric artery at the lower border of the pancreas and runs upward and forward in the transverse mesocolon. Here it divides into right and left fronts. Right branch, left front. Right branch of middle colic artery runs towards the right colic plexus. Here is the right colic plexus. And anastomosis with ascending branch of right colic here. And left branch of middle colic runs towards the left colic flexor and anastomosis with the ascending branch of left colic. Left colic is branch of inferior mesenteric artery. Okay, inferior mesenteric artery is giving left colic, sigmoid branches and continues downward as the superior rectal artery. Okay, so this is middle colic. Next is right colic. It arises on the right of the superior mesenteric artery, passes to the right behind the peritoneum, divides into ascending, descending branches. Absence of it is very common variation. Okay, ascending branch of right colic ascends upward, anastomosis with the right branch of middle colic artery, and descending branch of right colic descends downward and anastomosis with ascending branch of iliocolic here. Okay, next we go to iliocolic artery. It arises from the superior mesenteric artery near the root of the mesentery. Here is the iliocolic. It descends towards the cecum, divides into superior and inferior branches. Superior branch of iliocolic runs along the left side of the ascending colon. Here is the ascending colon and this is the ascending branch. Anastomosis with the descending branch of right colic artery. An inferior branch of iliocolic artery descends towards the iliocolic junction. Here is the iliocolic junction. It gives these branches: anterior and posterior cecal arteries, appendicular artery, and iliac branch, ascending colic branch. All these are branches from this inferior branch of iliocolic artery. Next is appendicular artery. It arises from the iliocolic artery. This one is the appendicular artery. It descends posterior to the terminal part of ileum. Here you can see this is terminal part of ileum. Appendicular artery is passing posterior to the terminal part of ileum. Who is talking? Get out from here. It descends posterior to the terminal part of the ileum and enters the mesoappendix. Here is the mesoappendix. Reaches up to the tip of the appendix along the free margin. Okay, so this is appendicular artery. Next is jejunal and ilial branches. On this side, these are the jejunal ilial branches. You have seen also in previous picture. So jejunal branches, these are 4 to 6 branches, and that arise from the left side of the superior mesenteric artery, and they form 1 to 3 arterial arcades in the mesentery. Okay, the arterial arcades you will see there, and the terminal arcade gives straight long vasa rectum. Okay. Then ilial branches, 8 to 12 branches that arise from the left of the superior mesenteric artery, and they form 2 to 6 more in number. Okay, 2 to 6 arterial arcades in the mesentery, and the terminal arcades give short vasa rectum that I have explained previously in this diagram. And note, only jejunal and iliac branches arise from the left of the superior mesenteric artery, whereas all other branches, that means the colic branches, all arising from the right side of the superior mesenteric artery. So to visualize the branches of superior mesenteric artery, clean the peritoneum and fat covering these branches. You have to clean all those things. Yesterday we did. Next, see, this is jejunum. These are the arterial arcades and windows formation, and these are the long vasa rectum. And for the ilium, see, windows are more in number, peritoneal windows, and these are the vasa rectum. They are short in length. Okay, understood? That's how you differentiate between jejunum and ilium. 3 to 6 rows of arterial arcades, 1 to 2 rows of arterial arcades. And here the peritoneal windows are opaque. That means you cannot see properly. If you hold it against light, you cannot see properly the peritoneal windows because fat is more. And here the fat is distributed near the root of mesentery, and the fat is less in amount. That's why peritoneal windows you can see, they are more transparent. Okay, if you hold it against the light, you can see clearly these peritoneal windows. Okay, understood? Next. So these are the jejunal and iliac branches. So this is branch from the superior mesenteric artery. Here it is showing the branch from inferior mesenteric artery. Left colic, sigmoidal branches, and continuation is the superior rectal arteries. Okay. So all these arteries, they are together. Here the colon has been cut at the junction of right 2/3 and left 1/3. Up to this right 2/3, this forms the midgut, and rest of the part here, this is forming the hindgut. Hindgut is supplied by this inferior mesenteric artery. Okay. So all these arteries, they are together forming a continuous anastomosis around the large gut. And from this anastomosis, these vasa rectors are entering to supply the large gut. This continuous anastomosis, this is known as marginal artery of Drummond. Okay, this is very frequently asked in your viva. What is marginal artery of Drummond? Okay, next. So marginal artery of Drummond, it is formed by the anastomosis between the colic branches of superior and inferior mesenteric arteries. It begins by anastomosis between the iliac branches of iliocolic and termination of superior mesenteric artery. Ends by anastomosis between the sigmoid branches of inferior mesenteric with the superior rectal artery. And from the marginal artery, straight end artery is known as vasa recta. Straight, that's why name is recta. Recta means straight. Okay. So vasa recta supply the large intestine. Next. Okay, that's all.